Hello, everybody. Thank you so much for joining this call. I have the pleasure of introducing Dr. Reddy today, who's going to talk about amyloidosis. And a little before that, I want to give a shout out to a few teams. Dr. Reddy, if you want to click to the next screen. Just click on that. Yeah, click on that one. Yep, go ahead and click. I'll go back. All right. So this is the physician outreach team that really represents a lot of our programs, most of our programs and hospitals at Legacy. And I work on a great team of wonderful women who we have all helped make this happen. So I want to appreciate them. And depending on your location, you may have a different liaison. So this is our team, and feel free to reach out to one of us with any questions about education or provider outreach or getting connected more with Legacy. If you can go to the next slide. So this is part 4 of a 4-part series on heart failure by Dr. Reddy. You can find the other 3 talks on Legacy's YouTube page. So if you go to YouTube and just type in Dr. Reddy Legacy, as I did there in that screenshot, you can find the other 3 talks that are listed right there. So don't forget to do that. There's also some information in the chat field about how to find that information. So we are recording this talk, so just so you know, it is for CME credit. And Dr. Reddy will show you how to get that CME credit right as he starts the talk, as well as at the end. Please use the chat field for any questions that you may have. We can answer those during the talk and after the talk. So we'll move it along from there. Dr. Reddy, thank you so much for doing this in a 4-part series.
Thanks, Darren. So this is the last of our series on heart failure. It's titled an amyloidosis ATTR. The focus is on the ATTR, not so much on the AL. We'll talk a little bit about AL too. So the learning objectives are define amyloidosis, pathophysiology of amyloidosis, then discuss when to suspect ATTR, and summarize the non-biopsy diagnosis of ATTR, and the latest in the treatment of ATTR using Tafamidia. So I have no disclosures. And this is the information on how to obtain CME. And if you have any questions, you can always email us at that address here. So with that, so what is cardiac amyloidosis? So cardiac amyloidosis is a form of restrictive cardiomyopathy due to deposition of an abnormal protein called amyloid in the myocardium. So I thought the first few slides, I will talk about the basics of cardiac amyloidosis, and then I'll present 4 different clinical situations and see how we use what we discussed in the first part. So what are the main types of amyloidosis? There are a number of types, but there are mainly 2 types. One is AL. A stands for amyloidosis and L stands for the light chain. So this is called light chain amyloidosis. And the second group is called ATTR. So the TTR stands for transthyretin, and A stands for the amyloidosis, so transthyretin amyloidosis. So TTR is actually a protein which is normally produced in the body, and this is a transporter protein for thyroxine and retinol in the body. Within ATTR, there are 2 different types. ATTRwt, or the wild type variant. Previously, it used to be called senile amyloidosis. And the other is ATTRm, or the mutant variety, or mutant variant. It's also called hereditary type ATTRh. They both mean the same. So So basically two types, AL, ATTR, and within ATTR wild type and either mutant type or hereditary type, whichever terminology you would like. So this is the pathophysiology. On the left-hand side of the picture, it shows the AL pathophysiology, and on the right side it shows the pathophysiology for ATTR. So AL is basically a problem of bone marrow. So bone marrow cells produce plasma cells, and to put it simply, AL is actually a neoplasm of the plasma cells. So plasma cells produce immunoglobulins, and these immunoglobulins, they are misfolded. The light chains of these immunoglobulins undergo misfolding, and that forms the amyloid protein, and that amyloid protein gets deposited in the heart. So this is a bone marrow problem. Plasma cell light chains of the immunoglobulins turn into amyloid protein, and amyloid deposits in the heart. On the contrary, in ATTR, the protein is produced in the liver, and this protein is called TTR, or transthyretin. As you can see, there are 4 subunits, 1, 2, 3, 4. And in a healthy form, all 4 subunits are held together as a single unit and a single protein. So in patients with TTR, the TTR protein is disorganized, or it dissociates into dimers or monomers, and those then misfold into fibrils, and those fibrils are then called amyloid fibrils, and they get deposited in the extracellular space in the heart or in tissues which are affected by the amyloid. So ATTR is a liver problem, and AL is a bone marrow problem. So what are the clinical manifestations? Are usually common to both AL and ATTR. When you see AL, it means amyloid. AL amyloidosis. WT means wild type, and when you see H, it is hereditary or the mutant variety. So with regard to heart, shortness of breath, orthopnea, edema, and right heart failure, so more common in AL type. Aortic valve stenosis is more common in wild type. Atrial fibrillation, flutter, they can occur in any type. Heart blocks, again, more common in wild type. With regard to neurologic system, carpal tunnel syndrome, more prevalent in wild type and hereditary type. Lumbar spinal stenosis is more common in wild type and hereditary type. And peripheral neuropathy, AL type and hereditary type. Orthostatic hypotension, AL and hereditary type. Kidney, mostly in AL. It's proteinuria or renal failure or renal insufficiency. Gastrointestinal manifestations, weight loss, nausea, early satiety, diarrhea, and constipation. So those are the clinical manifestations. And what are the red flags for cardiac amyloidosis, or when to suspect cardiac amyloidosis in patients? So when you're reviewing an echocardiogram or reporting an echocardiogram, you will see thickening of the left ventricle. So LV hypertrophy or LVH, and usually they are usually greater than, the thickness of the LV is greater than 1.2 centimeters. And when you're reviewing the ECG, usually patients with left ventricular hypertrophy should have large amplitude ECG complexes, but there is a discordance between the echo findings and the ECG findings. So patients have left ventricular hypertrophy and low voltage ECG complex. So when you see an ECG with low voltage ECG complex, but the echo shows LVH or left ventricular hypertrophy, That's one of the red flags for amyloid. And if you see thickening of the right ventricular free wall or thickening of the valves, intolerance to beta blockers or ACE inhibitors. This is one of the patients I'm going to present had this particular red flag, low normal blood pressures in patients with a previous history of hypertension. This means that people were diagnosed with hypertension in the past, they were on medications, whatever you name, lisinopril, carvedilol, amlodipine, and now they are getting hypotensive and you're having to peel them off of these antihypertensives. And history of carpal tunnel syndrome and requiring surgery. Then on the AL type, heart failure with preserved EF, nephrotic syndrome, macroglossia, periorbital purpura, orthostatic hypotension, peripheral neuropathy, or monoclonal gammopathy of unknown significance. And the ATTR, which we are going to focus on today, is men equal to or greater than 60 years of age with heart failure with preserved EF. I repeat this, men equal to or greater than 60 years with heart failure with preserved EF, plus history of carpal tunnel syndrome or spinal stenosis. And African Americans, 60 or older with heart failure with preserved EF without a history of hypertension. Because hypertension, as we know, is a risk factor and it causes both LVH and heart failure with preserved EF. So when somebody has LVH, the common causes are hypertension, aortic valve stenosis. So if they don't have hypertension or aortic valve stenosis, but they do have LVH and they have heart failure with preserved EF, and if they are men over 60, Caucasian or African Americans, that's a red flag. New diagnosis of hypertrophic cardiomyopathy in an elderly patient. New diagnosis of low flow, low gradient aortic valve stenosis in an elderly patient. And family history of hereditary or mutant variant of ATTR. So these are all the red flags. And if you see any of these, then that should prompt you to be thinking of amyloidosis and testing in that direction and referral to either an amyloidosis center or cardiology with heart failure. Then what are the basic tests? So elevated BNP and mild troponin elevation on different occasions. So they tend to have persistently elevated troponins in the absence of coronary disease. Abnormal free light chains and positive serum and urine electrophoresis and immunofixation. Then when you're reviewing the ECG, low voltage complexes, like we said, in patients with LVH, they should have higher voltage complexes, but in these patients, they have left ventricular hypertrophy, but low voltage QRS, and they have pseudo-infarct pattern, and we have an ECG for all of this. LV hypertrophy on transthoracic echocardiogram, and relative low voltage QRS. On the echocardiogram, they usually have concentric LVH, they have right ventricular hypertrophy, they may show small pericardial effusion, and apical sparing of the longitudinal strain. This is more for cardiology. So what happens in amyloidosis is the basal and mid segments are more affected than the apical segments. So the longitudinal strain in the basal and mid segments is a lot lower compared to apical segments. So that is called the apical sparing of longitudinal strain. And cardiac MRI, you have diffuse subendocardial late gadolinium enhancement and other specific testing, including increased extracellular volume. So those are the basic tests. Of course, cardiac MRI is not a basic test, but I would say blood work, ECG, and transthoracic echocardiogram are the basic tests.
You have a question there, see what that red one is?
Yeah. Why do patients switch from being hypertensive to low or normal with amyloid? So that's a very good question. So when patients have amyloidosis, there's infiltration of the myocardium with amyloid protein, and that makes the heart stiff, and that causes restrictive cardiomyopathy, and restrictive cardiomyopathy causes low cardiac output state, and low cardiac output state causes low blood pressure. So those are the basic tests, and now this is the algorithm, and I'm going to show the same algorithm 2 or 3 times during this presentation, so we all understand this well. So let me take you through the algorithm here. So on the top box is symptoms, ECG, echo, MRI, or biomarkers suggestive of cardiac amyloidosis. So we talked about the symptoms, we talked about the ECG findings, we talked about the echocardiogram findings and MRI. And you don't even have to do the MRI. The symptoms are suggestive, ECG is suggestive, echo is suggestive, and BNP and troponin. Then you go to the next step, which is screen for the presence of monoclonal spike or monoclonal protein. So that the way you do it is you order serum light chain assay. Serum light chain assay, this basically looks at the ratio of the kappa and lambda proteins in the body, and the normal range is 0.26 to 1.65. Anything less than 0.26 is abnormal. Anything greater than 1.65 is abnormal, with a caveat in patients with the kidney disease, the numbers are slightly different. Serum protein immunofixation and urine protein immunofixation. So when fortunately, our lab at Legacy, when you order serum protein electrophoresis, it has a reflexes to immunofixation. The same way when you order urine protein electrophoresis, it automatically reflexes to immunofixation. So if in other places, I am not sure, but you specifically need to order serum protein immunofixation and urine protein immunofixation and not electrophoresis. So clinical suspicion, you order these 3 tests, and one or more of these tests is abnormal, then you go down this pathway, which is referral to hematology, and that entails fat pad biopsy, bone marrow biopsy, and if the fat pad biopsy and or bone marrow biopsy is positive for amyloid, then the patient has either AL, ATTR, or other amyloidosis. And if it is negative, then cardiac amyloidosis is unlikely. And if all 3 of the tests are negative, if all 3 of these are negative, then the next step is to bone scintigraphy. And the one that Legacy has is technetium pyrophosphate scan. And you send the patient for technetium pyrophosphate scan. And for now, it is done only at Legacy Good Samaritan Hospital. And they get that scan, and the scan is positive. And if the scan is positive with a grade 2 or 3 uptake, there are 4 grades, grade 0, 1, 2, and 3. And I have a picture for that. And if it is positive by grade 2 or 3, then ATTR amyloidosis is diagnosed, or that diagnoses the ATTR. And then you go on to do genetic testing to differentiate wild type from hereditary type. If you don't have a referral, if you don't have the bone scan, then you may send the patient to bone scan or invasive evaluation of the heart biopsy. So that invasive evaluation would be cardiac biopsy, and if the cardiac biopsy is positive, then ATTR, and then further genetic testing. If not, it's amyloidosis is unlikely. So like I said, we'll go through this a couple of times during this talk after each case situation. So the first case presentation, this is a 70-year-old woman. All these cases are the ones that I was consulted either in the hospital or in the clinic, and they all were seen at Legacy Manual. So this is a 70-year-old lady who presented for evaluation of tiredness, fatigue, and lower extremity swelling for about 4 months. So I think this patient was admitted in 2017 here at Emmanuel. So she was hypertensive, and normal heart rate, 37 degrees centigrade, respiratory rate was normal. She was a very thin, small, petite lady. Oxygen saturation on room air was 94%. Her JVP was elevated. She had bilateral lower extremity pitting edema. So the clinical presentation based on symptoms and examination was consistent with right heart failure. And this is the ECG. I would like you to focus on a few things here. So this is a lead 1, 2, 3, standard limb leads, AVR, AVL, and AVF. This is V1 to V6. So if you look at the limb leads, the ECG complexes are low voltage ECG complexes. So by definition, they should be less than 5 small boxes, and they're all less than 5 small boxes. And if you look at lead 2 here, this is the P wave, QRS, and that's the PR interval. And this is the PR interval here, slightly longer. This is the PR interval, slightly longer. And there's probably a P here, and there's a missed QRS. So this is typical for Wenckebach or Mobitz type 1. So the same thing repeats here, the same thing repeats here, and the same thing repeats here. So on this ECG, we have low voltage ECG complexes and Wenckebach, which is heart block. So we have 2 positive findings. And this is the same ECG. This is the ECG on the same lady the following day. So the Wenckebach is gone. The low voltage ECG complexes still persist. And if you look at the QRS progression from V1 to V6, there is decrease R wave voltage, concerning for possible anterior infarction. She never had a heart attack, but this represents the pseudo-infarct pattern. So she has 3 findings on her ECG: low voltage ECG complexes, Wenckebach, and pseudo-infarct pattern, which are typical for amyloid. And this is an echocardiogram, and this is the long axis, short axis parasternal long view. Then this is the left atrium, mitral valve, left ventricle. This is the right ventricle, interventricular septum, aorta, and aortic valve. And what is being depicted here is a thick interventricular septum and a thick posterior wall or infralateral wall. So to be specific, the septum measures about 1.2, and the posterior wall measures about 1.4. And this is the a different view of the echocardiogram. And you can see here biatrial enlargement, thick interventricular septum, and the sparkling granular appearance that is seen in some patients with amyloid. You can see pericardial effusion, and she also had some pleural effusion. So she has concentric LVH, she has biatrial enlargement, she has valvular thickening, she has pericardial effusion, and she has that granular sparkling appearance of amyloid. This is as typical as amyloid can get. And it's the same picture in a short axis. You can see thick left ventricle and right ventricle, and this is the pericardial effusion. And these are the Doppler values. So we look at the ratio of E to A, and the E wave is a lot skinnier, and we look at the deceleration time. So when you look at the E to A ratio of 1.9 or 2, in conjunction with a decreased E prime value, which is only 5, the normal number is 8 or higher. And then you look at the E to E prime ratio of 18.8, which is 19, the normal should be less than 9. So when you put all these things together, LVH, restrictive left ventricular filling, and ECG changes, the diagnosis is right here. They're all in favor of restrictive cardiomyopathy. Then we went on to look at the blood work. As we said, the BNP is elevated. And the thing about troponin is there is no increase or decrease or rise and fall. There is no significant rise and fall in troponin levels. They are almost the same. And that is typical of amyloid 2. And then we did the serum light chain, light free chain assay. And the normal is 0.26 to 1.65. The patients was 0.04. Then there was a monoclonal spike noted on immunofixation. However, abdominal fat pad biopsy was negative for amyloid. We did bone marrow biopsy, normal cellular marrow, and there were monoclonal plasma cells, 10 to 20%, but there was no amyloid. So far, everything pointed to amyloid. So we'll go through this algorithm again. Her symptoms and clinical presentation, ECG and echo were consistent with amyloid. We went on to the next step, which is the kappa lambda ratio, protein, serum immunoelectrophoresis and immunofixation, and urine. And so all three were positive. So we went on this a part of the algorithm, and we did the fat pad biopsy that was negative. Bone marrow biopsy did not show amyloid. So what next? So everything pointed to AL amyloidosis, but could not identify the amyloid on tissue. So I sent her to a tertiary care center where they do biopsies, and she had a cardiac biopsy that confirmed amyloid. And as all this was happening, her son and daughter both came to visit her. I think the son was in Boston and the daughter in Illinois. So we talked about prognosis and treatments, and she went to live with her daughter in Illinois, and the plan was for her to be seeing amyloid specialist at Northwestern University for ongoing treatment. So that was a classic case of AL amyloid in a woman who is 70 years of age. And the second patient is also a woman, but she's an African-American woman, history of hypertension, stroke, cocaine use, right femoral neck fracture, admitted for sudden onset of severe shortness of breath. And this happened around 2 a.m. and she came to the ER, respiratory distress, chest X-ray was suggestive of pulmonary edema, elevated troponins, elevated BNP. So patient with some CAD risk factors, pulmonary edema-like picture, positive troponins, so cardiology consultation for acute coronary syndrome and NSTEMI. So I was involved. I was asked to see the patient for ACS, NSTEMI, and possible coronary angiogram. So this is her ECG, sinus tachycardia. As you can see, there the voltages are all normal. There is no evidence for low voltage, and there is some evidence for LVH on the ECG, and there are some ST depressions in the lateral leads. And this is her chest X-ray, normal sized heart with pulmonary edema kind of picture. So does she have ACS and STEMI or does she not? So before you answer, the devil is in the details. So let's go to the details. So troponins are 0.10, 0.12, and 0.12. So there is no rise or fall in troponins to suggest an ACS. Her BNP, again stable, elevated but stable, and both are fairly commonly seen in amyloid. And her LVEF was 40-45%. So she's in the heart failure with preserved EF range. Then there was mild concentric LVH. Then there was restrictive left LV filling pattern, and there were elevated LA pressures. So when I put this whole clinical presentation and these data, lab data and echo data, then what do we think? Is this still ACS and STEMI? I don't think so. So what does this clinical presentation suggest? So this clinical presentation suggests acute diastolic heart failure with preserved EF with possible amyloid. So what did we do? We went through the same algorithm: serum light chain assay, serum immunofixation, urine immunofixation, Serum light chain assay. So kappa lambda ratio was abnormal. Then immunofixation, IgA free lambda protein spike, so monoclonal spike. So bone marrow biopsy, she went on to have bone marrow biopsy and cardiac MRI, and she has IgA multiple myeloma and AL cardiac amyloidosis. So 5 to 10%, literature says 5 to 10% of patients with AL amyloid may have multiple myeloma, and 5 to 10% of patients with multiple myeloma may have coexisting AL amyloidosis. So this is a typical example of that. So she has both AL amyloidosis, cardiac, and IgA multiple myeloma. So she's being treated by oncology and heart failure cardiology. So she sees me every 3 to 4 months, and she's doing fairly well from cardiac point of view. No hospitalizations after, probably it has been 10 months since she has been admitted. That brings us to the third case. So this is an 81-year-old man, long-standing AFib, Wenckebach, second-degree heart block, orthostatic hypotension, chart history of CAD, aortic valve stenosis. Then ongoing shortness of breath for 3 to 4 years. For 3 to 4 years, he has been having shortness of breath. He underwent evaluation by EP, interventional cardiology, invasive evaluation of the aortic valve area, so showed that he only has moderate aortic valve stenosis. He had cardioversions, dofetilide, but he was still short of breath. So on an average, at least the literature says that it takes 36 months. It takes 36 months before a patient with amyloid gets the diagnosis of amyloid. So we are in that A. And it also says, literature says, at least 1/3 of patients with amyloid end up seeing about 5 different doctors before they get the diagnosis of amyloid. So we are there. So what next? So he has multiple risk factors for amyloid: age, gender. So ATTR is 9-to-1 ratio men to women. So 9 men, 1 woman. So it's a male predominance and elderly people. And atrial fibrillation is a risk factor. We went through the red flags: Wenckebach, aortic valve stenosis, orthostatic hypotension. So he has multiple risk factors for ATTR. And ECG showed low voltage ECG complexes. And transthoracic echocardiogram showed concentric LVH, grade 2 diastolic dysfunction, and aortic valve stenosis. In the interest of time, I'm not going to show you the data. I already showed you the classic data on the previous 2 patients. And his findings were similar to that. So when I put all this together, what testing is indicated? So serum light chain assay, serum immunofixation, urine immunofixation. So we went through the same algorithm. And all of these are negative. All these were negative. So what next? So we go through this algorithm again. So clinical suspicion was high. Then we went through sent to the next second step. All these 3 were normal. So we went to bone scan, and let's see what the bone scan showed. So this is not patient's bone scan. This is actually a picture I took from JAMA 2020. And this is how a technetium pyrophosphate scan looks like. So there is grade 0, grade 1, grade 2, and grade 3. This is the skeletal picture, and this is the heart picture here. And what they are asking you to look at is the uptake of the tracer by the heart. So when you see grade 0, the cardiac region is clear, which is here. The cardiac region is clear, and you can also see the cardiac region is clear. Ribs and sternum are opaque. So this is the sternum, these are ribs. So the tracer is in the sternum and ribs, but not in the heart. So to say, so a grade 0 would be there is tracer in the ribs and the sternum, but none in the heart. Grade 1 would be slight opacity of the cardiac region, slight, and you can see it here, slight opacity, but less than the sternum or ribs. And grade 2, there is increasing uptake of the tracer in the heart, which is similar to the sternum and ribs, more than here, but less than here, equal to the same density. And grade 3 is the uptake by the heart is a lot higher compared to the ribs or sternum. And you can see the difference from here to here. There's none, there's some, there's the same amount, and here greater. So for us to say that this is a positive scan in a patient with ATTR, it should be either grade 2 or grade 3. And this patient had grade 3, and we diagnosed him with ATTR. And that brings us to patient number 4, who has a similar history, but something different, which he had complete heart block in 2011 and had a pacemaker and spinal stenosis. And like we said before, spinal stenosis is a risk factor. And he was short of breath for 6 months. He saw me probably in mid 2019. This is a patient who gets his care between here and California. And his transthoracic echocardiogram revealed concentric LVH, and AF was 35–40%. So we went through the usual motion. So elderly patient, CAD risk factors, LV systolic dysfunction, and he's short of breath. So let's do an angiogram and right heart, no CAD, and heart failure therapies were started. And this is a patient who was known to have hypertension, and he was on medications for hypertension. And he went to California for a few months. There he was admitted for sepsis and prolonged hospital course. And then he returned to Portland, and he still had shortness of breath, and he's now getting hypotensive. And in fact, we had to slowly get him off of his regular antihypertensives. So what next? So he has multiple risk factors: age, gender, AFib, complete heart block with permanent pacemaker, history of hypertension, now getting hypotensive, and spinal stenosis. So that's his risk factor profile for ATTR. And transthoracic echocardiogram revealed concentric LVH, and he had the same free light chains, immunofixation, serum immunofixation, urine immunofixation. All of these were negative. And we went through the same scan, and he had strongly positive, and he also was diagnosed with ATTR. So I showed you 2 patients with one patient with AL, one patient with AL amyloidosis and multiple myeloma, 2 elderly male patients with ATTR. This is just one thing about carpal tunnel syndrome. This picture shows you cumulative risk of amyloidosis, heart failure, and death in carpal tunnel syndrome versus control patients. So I just want you to see this picture B. This is risk of heart failure. So the blue line is patients with carpal tunnel, and red is the controls. It's obviously high, and not so much on the death and the incidence of amyloid. So the incidence of amyloid is higher, and incidence of heart failure is higher in patients with carpal tunnel syndrome. And this is the timeline. They start around here with history of carpal tunnel syndrome, bicep tendon rupture, lumbar spinal stenosis. And by the time we see, they are here. So we need to catch them somewhere here. So what are the therapies that are available? So there are medications, and this is all from 2018 publications. Until then, we didn't have anything for ATTR. So there are agents that block the synthesis of ATTR, and there are medications that actually stabilize the ATTR, TTR, keep it in a tetramer form and prevent it from dissociating into dimers or monomers and thereby causing fibrils. And there are therapies which remove the fibrils. So for today's purpose, we are only going to talk about the stabilizers. And this study came out in New England Journal, September 13, 2018. Tafamidis is the name of the medication, and it's a TTR stabilizer. And the primary endpoint was all-cause mortality or heart failure hospitalizations. Obviously, patients with who were given tafamidis did well. And this is the key. So early detection and early treatment. So here you see the survival, and here you see the cardiovascular hospitalization. And here I want you to pay, focus on NYHA class 1 or 2, and class 3. So class 1, of course, survival, 1 or 2 survival benefit, and cardiovascular hospitalization a lot lower in patients with NYHA class 1 or 2. When you get down to class 3, NYHA class 3, it does not help, probably does not help, and probably may actually increase the cardiovascular hospitalization. So the point of this picture is to catch them early and send them early and start the treatment when they are in NYHA class 1 or 2 to get the benefits. Conclusions. Watch for the red flags for amyloid, particularly low flow, low gradient, aortic valve stenosis, spinal stenosis, carpal tunnel syndrome. Early referral to cardiology or heart failure cardiology or amyloid center. And there are treatments for ATTR provided we catch them early in NYHA class 1 or 2. And both my elderly male patients are on tafamidis, and the first one was started on tafamidis in September of last year. He's still doing okay, has good days and bad days. The second patient was started on tafamidis in April of this year, and I haven't seen him back yet. So that's all I have, and I'll take any questions.
So you can feel free to unmute yourself, or you can type questions in the chat field. And Dr. Reddy, if you want to go to the next slide, just so everybody knows, that's if you want to take a get out your phone and grab that UR code that's right there. You can claim CME credit for this talk. We are recording this conversation or this talk, and we'll be making it available on YouTube later. So feel free to unmute yourself and ask any questions. One question I have for you, Dr. Reddy. Yes. Can you tell everyone where you see patients here in Portland?
So Legacy Heart Failure Clinic is stationed at Legacy Emmanuel Medical Center. And I'm heart failure trained and board certified. And I also run the program as the medical director. And we have a nurse practitioner, Lena Rossetti-Grolich. We have a heart failure RN, Susan Bladen, and we have Charles Griffith, our heart failure MA, and we have social worker Miranda Meng, who works very, very closely with our heart failure patients with social needs. In fact, to tell you, give you an example, when I first started the tafamidis on my first patient, the 81-year-old, the cost of tafamidis is $18,750 per month, and she got it for us for $30 per month.
Wow!
And the second patient I started, again tafamidis, the same. It would have cost him the same thing, $18,750. And through insurance and whatever the discounts, now he's getting it for, I think, $1,100 a month, something like that. So it's an expensive drug, but there are programs. Our social worker knows, Miranda knows, and we can get them enrolled and get the treatment going.
So so you see patients here at Legacy Emmanuel and out in Gresham at Mount Hood as well.
Yes, we also go. Our team also goes to Mount Hood Medical Center in Gresham once a month. Yes, sorry.
Well, I don't think there's any questions from the group, so we will leave you all here. Thank you so much for joining this talk, the fourth talk in our heart failure series. Again, if you want to see the other 3 talks from Dr. Reddy, you can go to the YouTube site. I have put the link in the chat field, but if you go to YouTube and type in Dr. Reddy Legacy, you'll be able to find the previous 3 talks. And this one will be available on YouTube here in the next couple weeks. Thank you very much, everyone, for joining, and appreciate it, and hope you have a great weekend.